Thank you very much. So I'm just going to share my screen now as we move on to the next workshop. So hopefully you can see that now. My name is Christina Messiou. I'm a consultant at the Marsden. It's a real pleasure to be with you today. I have no conflicts to declare, I should say, before I go on. So over the next half an hour, I'm going to be running through the differential diagnosis of retroperitoneal and abdominal mass lesions. I think most of the cases are retroperitoneal. I have to confess that my bias is that one of my interests is soft tissue sarcomas. So the teaching will also incorporate when to recognise the commoner soft tissue sarcoma cases. Now, particularly when masses arise in the retroperitoneum, one of the challenges for us is that the presentation can be really diverse, and sometimes there are incidental findings. So we don't always, I think almost any clinician can find themselves trying to figure out the differential diagnosis of retroperitoneal mass. So, for example, this patient here was seen by the trauma team, and you can just about see that the patient had some rib fractures, but he also had a huge retroperitoneal fatty mass. The next elderly lady, or 79-year-old, so not so old actually, was being looked after by the GI team with biliary sepsis, and she had an incidental contralateral retroperitoneal mass. The next patient's being assessed by urologists for a swollen testicle, and again, this patient has another very different looking retroperitoneal mass. And then finally, this patient presents to accident and emergency with chest pain, has bilateral pulmonary emboli. And thankfully, they investigated for an underlying cause and found an external iliac vein mass. So if you don't instantly know what the top differential or top two differentials are for these masses, then hopefully in about 20-25 minutes you will. I think the key to looking at these indeterminate masses is to have a sort of systematic way of looking at them. And for me, if the masses aren't clearly arising from one of the solid abdominal viscera, the first question I ask myself is there evidence of abnormal fat? And you have to have a very purposeful look for that fat because it's not always obvious. If you do find fat, carefully interrogate to see whether it's coming off the kidney or the adrenal. Could this be a benign renal angiomyolipoma or an adrenal myelolipoma? And if it's not coming off the kidney or the adrenal, it could be a liposarcoma. And although there are other fat-containing benign lesions in the retroperitoneum, at that point it really is worth considering sarcoma and referring on for an opinion. But if it's not a fatty mass and we're considering a solid mass, think about whether the patient demographics might suggest germ cell tumour. Could serum markers be helpful? Make sure the staging is complete. You know, is there a primary tumour that we're missing or metastatic disease that helps us with the differential? Now, remember, for a solid mass in the retroperitoneum, it can still be a liposarcoma even if you can't see abnormal fat. It may be that the whole tumour has differentiated. Look and see if the mass is coming from a vein, because if it is, it's probably a leiomyosarcoma. Look for nodes, of course, because if you see nodes associated with the mass, could it be lymphoma, adenocarcinoma, or even melanoma? Sarcomas don't tend to spread to nodes. So if you see nodes, it's unlikely to be a sarcoma. There's some very rare subtypes that do spread to nodes, but really that's extremely rare. There are a whole host of benign pathologies in the retroperitoneum, particularly schwannomas. So we see quite a lot of schwannomas in our sarcoma MDC. So we'll look at a few of those. And there's a small number of sarcomas that, even though they're rare, they have quite characteristic imaging appearances. So I'm going to introduce you to some of those as well. So we're going to move on to the cases. I would really encourage you to vote very quickly, almost as soon as you see the images. We've got 13 cases. Ideally, I'd like us to get through all of them. I'm not sure that we will, but we'll do our very best. There is an interactive voting system. Let's try and use it, but if we feel that it slows us down too much, we might move on without it. But let's look at this first case and see how we go. So, do you think this mass above the kidney is an RCC, an adrenal carcinoma, a liposarcoma, or an adrenal myelolipoma? There is a feature on this scan that clinches the diagnosis, so it's spotting that additional finding. So please do vote now. Fantastic. And if I could see the results now, even if they're not all through, that would be great. Just looking at, I've got my other screen on this, but I can see the same that you can see, so I can see where you're up to. So have you spotted what it is that clinches the diagnosis for us? So most of you have said that you think it is an adrenal carcinoma, and I can absolutely see why you would have said that, because we've got a suprarenal mass. But actually, some of you got it right and spotted the abnormal fat below the kidney. So this is a liposarcoma. So unfortunately, the local institution didn't spot the abnormal fat either. The mass came out with the kidney, but they didn't take out the entire tumour. They left behind the fatty component. And only 2 months after the nephrectomy, this patient has got recurrent disease in their surgical bed, which is really terrible. For patients with sarcoma, their best chance of a good outcome is that first operation done in a high volume specialist centre. So it's a real shame for this patient. This is another case, just to show you an example of another case that was assumed to be a renal mass, and they missed the abnormal fat here. So you can see after the operation, that abnormal fat has been left behind. So again, that patient's missed their chance of the best outcome. So the learning points here are that liposarcoma has quite a spectrum of appearances. It can be bland, well differentiated, or more solid, dedifferentiated disease. Liposarcoma is the commonest sarcoma in the retroperitoneum. It can calcify, usually seen in the 5th to 7th decades of life. And the patients don't do as well as patients with limb sarcoma because of the surgical challenges. And something that I think isn't commonly known is that lipomas in the retroperitoneum are even rarer than liposarcoma. So if you see a bland fatty lesion in the retroperitoneum, it is actually more likely to be a liposarcoma than a lipoma. So the take home is always really, really look for that abnormal fat, because as you've seen in that case, it's not always obvious. So let's make sure the patients end up in the hands of the right surgeons. So these are surgeons from a number of units from all over the world that do high volume sarcoma surgeons. So remember these faces and remember to look for the abnormal fat. Okay, case number 2. Okay, do you think that this abnormal fat in the retroperitoneum relates to well-differentiated liposarcoma, dedifferentiated liposarcoma? Could it be a lipoma or a renal angiomyolipoma? And again, a bit like the first case, there is a single finding on this scan that helps us clinch the diagnosis. So one of these images shows us a nice feature. So again, vote really quickly and let's see what you think the diagnosis is. And just have a go, because remember that nobody or individual people are voting. This is really just to have a bit of fun and see what most of us think. So can you spot the key feature that helps us get this one right? So I think it's a bit 50-50, but actually 40% of you voted for renal angiomyolipoma, and you would have been correct. So you guys must have spotted the renal cortical defect here. So that is what clinches the diagnosis of an angiomyolipoma. And these are really common benign masses in the retroperitoneum. And the key to getting the diagnosis is to look for the sort of ground glass change, the prominent vessels, but it's really that renal cortical defect that gives us confidence that this is a renal angiomyolipoma. Now, this is a tricky case, 26-year-old with an abdominal mass. So make a note of the age when you start to think about this. I've shown you a slice through the inguinal region for a reason. Do you think it's a myxoid liposarcoma, solitary fibrous tumour, germ cell tumour, or lymphoma? So vote now. And let's see what you guys think. Do we have any votes in for this one? So we've got a vote through for solitary fibrous tumour. A couple saying germ cell tumour. So I'm going to show you the result. So I think this is a really tricky case, and this was a germ cell tumour. So it's the age of the patient that makes us think about germ cell tumour, but also the fact that this patient's got a missing spermatic cord. So genuinely, when this patient was referred to us for review of the imaging, the referring centre didn't tell us that this patient had had a testicle removed for germ cell tumour. So this is recurrent germ cell tumour. So I think that was a really tricky case. So remember, particularly males and young men, think about the possibility of germ cell tumour. You could do tumour markers to help you with this differential diagnosis. Now, there's a second really important take-home message from this case, and that is, if you got this right, then you may be as clever as our president, Smarty Pants Aslam Sohaib, who did get this right first time very quickly. So well done him. Right, case number 4, 53-year-old female with abdominal discomfort. Do you think this is a myxoid liposarcoma, lymphoma, leiomyosarcoma, or germ cell tumour? I don't think we can say absolutely what we think this is based on this imaging alone, but start thinking about those questions that we spoke around in that sort of decision-making algorithm, and one of these starts to become most likely. So do vote quickly, and if I can start seeing some results coming through on my chat, that would be great. Any results through yet? Ah, brilliant. So I think most of you, 85%, thought this was a leiomyosarcoma, and that's absolutely what it is. It's a mass completely replacing the IVC. This is a classic appearance for leiomyosarcoma. They usually come off the IVC, but they can occur off absolutely any venous structure. And unfortunately, about half of these will have metastasized by the time that they present. So the take-home message is, if it's coming off a vein, think leiomyosarcoma. Just to show you some examples, this is one coming off the renal vein. This is the external iliac vein leiomyosarcoma that resulted in the PEs that I showed you at the beginning. And this huge one was actually coming off the gonadal vein. So remember to think about the origin of the mass. Okay, let's go on. The clinical history here is really important. 49-year-old male with ulcerative colitis. I think the imaging on its own is potentially quite difficult to interpret, but if you put the clinical history together, do you think this is more likely to be a myxoid liposarcoma, a leiomyosarcoma, a desmoid, or lymphoma? I think this really is quite a tricky case, but let's see what you think. Any results coming through? So it's relatively bland, isn't it? But quite a young patient. I think, yeah, we've got some good answers here. Mainly C. That's absolutely what this patient has. It's a desmoid tumour, and the key here was the ulcerative colitis, because desmoids are more common in FAP, but also inflammatory bowel disease. Tend to see them in people in their 30s to 40s. They do very well after resection, unlike fibromatosis in the extremities, where we really don't like to resect because local recurrence is common. The abdominal ones actually do quite well. Remember also that desmoid tumours or fibromatosis is a very, very common cause of a mass in the anterior abdominal wall in young females. Okay, so desmoid. So well done to those of you who got that one. The other thing I want to say about desmoids is that often the first imaging that we do for the abdominal desmoids is a CT scan. And on CT, they can look very bland and almost mimic lymphoma. On MRI, this is the classic appearance of a desmoid here. You can see the fibrotic looking elements and the more cellular looking parts. But sometimes, as I mentioned, on CT, they look really bland. So this one here, I think, looks very lymphoma-like. But when you look at the MRI, you can see it's very fibrotic. And similarly here for this mesenteric desmoid here. And so often the diagnosis, as you can imagine, comes down to a biopsy. Okay, we're doing okay. So next case is a 62-year-old anticoagulated with a sudden onset of flank pain. This is a really tricky case. And I don't think there's an absolute answer, but I'd be really interested to see what you would do next. Would you refer to a sarcoma unit, do a percutaneous biopsy, insert a drain, or do an interval scan? Answer now, and then we'll move on, and I will show you what happened next to the patient. No answers through yet. I think these cases of anticoagulated patients presenting with sudden masses or sudden pain are extremely difficult. So we've got an A and a B, quite a few people voting for D, to do an interval scan. So I think these are really good. So nobody wants to put a drain in, which is actually fantastic. Unfortunately, this patient did have a drain put in, and you can see that after the drain's been removed here, this tumour is now infiltrating the abdominal wall, and by the time the patient comes to us, there's substantial infiltration of the abdominal wall, and the patient, again, their chances of having a good resection is diminished. So I think the lesson here, I think these are extremely difficult cases. The lesson is that if there is hemorrhage in the retroperitoneum, we have to do our utmost to look for an underlying mass lesion and assume there is an underlying mass lesion. This is another case of spontaneous renal hemorrhage, and that was assumed to be benign, but there was actually an underlying renal angiosarcoma. So if in doubt, do have a discussion with your sarcoma unit and do your best to look for an underlying mass lesion, be it pre and post contrast imaging to help guide biopsy. It is often an approach that we use. Okay, case number 7, a 73-year-old male. All we were told when the imaging was referred to us that he had had a lymph node dissection 10 years ago. So I'll tell you that this had a Hounsfield unit of 15. Do you think this is a seroma, a lymphocele, a liposarcoma, or a germ cell tumour? So vote quickly. I think things are still coming through. Mainly B, lymphocele. I completely get that answer. You know, it really does look like a fluid containing lesion. I was just a bit suspicious. So actually we did an MRI, and you'll see the ADC also looks like it's a fluid containing lesion. But the T2 isn't quite as bright as the CSF, and there's some septations which enhance. So actually we opted to do a biopsy, and this was a liposarcoma. The reason it was so low attenuation is that it had a dominant myxoid stroma. So one of the messages to take home here is that myxoid tissue can mimic cystic etiologies. And there's no macroscopic fat because this liposarcoma has completely de-differentiated. I think this is a really tricky case, but always think about myxoid tissue. Here's, I think I've got another example. Yes, this is another patient who had a solid mass in the retroperitoneum without fat that was also a liposarcoma, so it can be very tricky. But just beware of that myxoid tissue mimicking cystic etiologies. Okay, case number 8. 59-year-old male with a pelvic mass. If you've seen one of these before, you might recognise it again. Have a go. Do you think this is an AVM, a GIST, a liposarcoma, or a solitary fibrous tumour? What I'm directing you at with the arrows here is some very, very chunky feeding vessels. I think this is a tricky case, and again, I don't expect you to get all of these right. This is really just to have some fun and learn as we go. Okay, mainly a vascular malformation. I think that's a very, very reasonable assumption. Actually, this was a solitary fibrous tumour. And now that you've seen it, if you ever see one again, you'll think of them again because they nearly always look like this. It's a type of sarcoma. They're nearly always more than 10 centimetres as they present, and they have very, very big feeding vessels. And the patients actually tend to do quite well after resection. These are 4 different solitary fibrous tumours, and look, they do have quite similar features, all huge with chunky feeding vessels. And Dirk, one of our local surgeons, says they look like big brains in the wrong place with chunky feeding vessels. So if you see that, think about solitary fibrous tumour. It's one of those tumours that is all about pattern recognition. So hopefully this should be a spot diagnosis for you, and you can vote even without me giving you some options. This is a 40-year-old male with a strikingly homogeneous retroperitoneal mass. Is this lymphoma, Germ cell liposarcoma, or is it metastasis? Which do you think it is? Very homogeneous. So that's the real clue to this, is the homogeneity. Mainly A, absolutely. So this was lymphoma, and it's the bland nature of this mass, as well as the fact that the vessels pass through and they're not attenuated. This was actually a patient who had presented with a mass in the back, and this tissue was so bland that we put lymphoma at the top of the differential, and that's absolutely what it was. Slightly different approach with this case. So 4 different patients, 4 different retroperitoneal masses. 3 of these patients have got benign nerve sheath tumours, and 1 of them has got a very aggressive malignant peripheral nerve sheath tumour. Which one do you think has got a malignant peripheral nerve sheath tumour? So vote now, vote quickly, and let's see what results come through. Can be quite a difficult differential to get right, because they can look very similar. But in this series, one of them is exhibiting slightly more aggressive behaviour. I think to move things on, mainly C so far, absolutely, because that is the one that is infiltrating the psoas. Now, malignant peripheral nerve sheath tumours are mainly of concern in patients with NF1, because it's the big and deep benign tumours that then undergo malignant transformation. So everyone's done very well there. Most people got the right answer. The nerve sheath tumours are just pushing things out of the way. And remember, cystic degeneration is very common even in the benign schwannomas. So these are classic appearances for schwannomas. Almost there. 63-year-old male with left flank pain and hematuria. So what do you think this is? Start voting. We've got a spiculate mass. It's clearly been around for a little while because that kidney has become very, very atrophic. Do you think this is lymphoma, liposarcoma, fibromatosis, or something else? And again, the clinical history here is really important. So get those votes coming in. And let's see what you think it is. See if I... Okay, so I think we've got somebody that's got a C coming through. So a lot of you think it's C, and about a quarter of you think it's D. So it is actually D. It is something else. Fibromatosis actually is quite an uncommon cause of hydronephrosis. It rarely causes hydronephrosis, is really what I'm trying to say. This was a TCC. So I've shown you lots of weird and wonderful things, but actually, if I'm to tell you that a 63-year-old man has got hematuria, you're thinking about looking for a TCC. And some of the more observant of you might have also spotted that there is an aortocaval node here. Now, sarcomas rarely cause hematuria because they compress from the outside in. So all of these factors are really helpful in directing us towards the diagnosis of a TCC. Now, I haven't gone mad. There isn't an image missing. I'm essentially asking you, what is the commonest cause of an anterior abdominal wall mass in a previously healthy 20-year-old female? So vote now. I actually gave you the answer to this earlier on. Do you think it's endometriosis, melanoma, liposarcoma, or fibromatosis? And I will show you the image after you've voted and show you the classic appearance. Wait for the results to come through. There's a few endometrioses, some liposarcomas. That's actually quite a blend of votes, I think. Most common, I think we've got, I think that's quite a range of votes, actually. It's interesting. But quite a lot voted for D, actually. So it is fibromatosis in at least 2 large series. The commonest cause of an anterior abdominal wall mass is fibromatosis. And this is the classic appearance of fibromatosis. You can see the fibrotic strands on T2 weighted imaging. And risk factors are the oral contraceptive pill, pregnancy, and previous C-section. Now, the first line management is surveillance, because a lot of these just disappear on their own, and they are very hormonally driven. So you can see this was a huge mass that had just completely disappeared at 2 years. So as long as the patient is not too symptomatic, we just watch these, particularly when they're in the abdominal wall. I'm going to skip through this one quite quickly, and perhaps we won't do an online vote because it just takes up a bit of time, and I want to get to just one more case. But this is another 20-year-old female with a very different abdominal wall mass. So this lady has got endometriosis, classic appearances with blood, T1 bright blood, fluid levels, and hemosiderin. And remember that the clinical history can sometimes indicate cyclical pain. So that's a real key to the diagnosis of endometriosis. 72-year-old male this time, with mass with coarse calcifications on the anterior margin of the right external iliac vessels. I've also shown you an image of the inguinal region, and that's not an accidental image. So that really shows you a key feature that clinches the diagnosis. So this isn't one of these cases where I'm asking for a most likely diagnosis. It really is, what is the diagnosis based on this scan? Is it lymphoma, germ cell liposarcoma, or chondrosarcoma? So vote now. All D so far, I think. So let's see. Nobody thinks it's lymphoma. A few people think it might be germ cell. A few people think it might be liposarcoma. And most people have said chondrosarcoma. Now, I can absolutely understand why you said chondrosarcoma. But the thing to spot here was the abnormal fat. So this clinches the diagnosis of liposarcoma. And it also means that you have assessed the extent of disease for appropriate surgical resection. So that abnormal fat clinches it. And this is the last case, a 32-year-old female with a palpable mass. Do you think this is lymphoma, D. diff liposarcoma, ovarian cancer, or synovial sarcoma? Have a little bit of a think about it and bring in some votes. And actually, just to kind of keep us on time, I'll start talking about the case as you're thinking about what you think it is. It's really too heterogeneous for lymphoma, I think. She's very young for D. diff liposarcoma, which we normally see, remember, in the 5th to 7th decades of life. I guess it could be ovarian, but it would be unusual. So this is a synovial sarcoma. I think the votes were split between B and D. And so well done for those of you who voted D. This is synovial sarcoma. These are usually seen in young adults and adolescents, can be relatively slow growing. And remember, they don't actually arise from synovium, although they are often seen around large joints. They're called synovial sarcoma because they histologically can resemble synovium down the microscope, so that they're not originating from synovium. And the slow growth sometimes means that they mimic benign etiologies, but really in younger patients, sometimes even very small nodules, we have to take them very seriously and undertake biopsy to ensure that we're not missing a diagnosis of some of these slower growing sarcoma subtypes. So I think in the interests of time, I'm going to end it there. And I hope you enjoyed those cases. I know that it was a really sort of fast moving series of cases, but I wanted you to see as many as possible. So thank you for your time. And I very much hope that you enjoy the rest of the conference.